Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. Premier education brought to you at no cost thanks to our sponsors, Medtronic, AstraZeneca, and our affiliate partner, Medela, the Science of Care. My name is Eric Lim, and this week it's a great delight for me to present my good friend and colleague, Professor Andrew Nicholson, who's recently worked on the updated diagnosis of mesothelioma to let us know a little bit about what's new. I'm going to start sharing my screen and a recording, and Professor Nicholson will take the questions live.
Hello, my name's Andrew Nicholson, and thank you for the invitation to speak as part of this program. It's very much an honour. I'm going to talk about an update on the diagnosis of mesothelioma. These are a few declarations, mainly to do with lung cancer. Most importantly, I trained as a light microscopist, and so molecular pathology is something that I have very much learnt during my career. I'm going to divide the talk into histology and immunohistochemistry, differential diagnosis, and molecular pathology, starting with histology and immunohistochemistry. In 2015, we already had the long-standing subtypes of epithelioid, biphasic, and sarcomatoid, dividing it morphologically into diffuse and localized, with two rarer variants, well-differentiated mesothelioma and adenomatoid tumor. There was also quite a lot of discussion of the variations with different prognostic significances, and the aim between 2015 and 2021 was to take this rather sort of haphazard distribution of various morphologies, cytologies, and stromal changes and make them more structured. So they were divided into architectural, and this also highlights the problems in differential diagnosis and the difficulties for pathologists, because mesothelioma can show a variety of epithelioid morphologies. It can look very similar to other metastases in lung, renal cell, small cell, rhabdoid, deciduoid. Can look very lymphoid. It can obviously be sarcomatoid, pleomorphic, and can show osteosarcomatous and chondrosarcomatous dedifferentiation. So with those variations, and looking at those with better prognosis and poorer prognosis, a publication came out in 2020 from the ISLC and Eurocan, proposing that these were itemized within reports going forward. And this is what was recommended and is part of the WHO classification that we currently use. The main changes from what we had in 2015 is the introduction of mesothelioma in situ, the introduction of grading, and this documentation of the various patterns. Just to say a little bit about grading, it's relatively simple in epithelioid mesotheliomas. We look at the nuclear atypia score, we look at the mitotic rate, and we look at the presence of or absence of necrosis and divide this into low or high grade. And this is now recommended for all epithelioid mesotheliomas. And I hope that when cases go into clinical trials, that this is included so we can identify whether or not this has value. There is some pushback, I think, from some people in the mesothelioma community as to what is the point of this, but I would argue that when we started with Gleason grading, there was little or no evidence as to its value, and it is now a mainstay of management. Mesothelioma in situ is now recognized. For this diagnosis, you need a mesothelial proliferation with no evidence of invasion, but with molecular evidence of abnormality, typically BAP1 loss or homozygous deletion of CDKN2A. It can't just be the pathology. It has to be a multidisciplinary diagnosis with clinical and imaging data showing an absence of nodular or invasive tumor. You can have a pleural effusion, but not with a mass. And the important thing with these various relatively new tests is they should I think, only be done in laboratories with experience, or at the very least in laboratories where they have validated the tests and you use appropriate antibodies. And these antibodies are BAP1 in association with BRCA1 protein tumor suppressor gene, CDKN2, a homozygous deletion. Immunohistochemistry for P16 has not really been that specific or sensitive, but MTAP, which is a protein that sits close to P16 on the chromosome, seems to have greater sensitivity and specificity. And most recently, with NF2 abnormalities, there is a antibody Merlin, but again, you have to have very thorough validation of these antibodies and know which clone you are using and the various issues related to those clones. So in relation to the differential diagnosis, the first thing for a pathologist is this a malignancy? And then we go to, is it a mesothelioma? So in relation to the, is it malignant? We have, as we've just discussed, either invasive or mesothelioma in situ, but we also have reactive fibrous pleuritis against sarcomatoid mesothelioma, particularly the desmoplastic variant. And in this situation, these new antibodies, which we've just discussed, are very valuable. Here we have something which probably would have been called an atypical mesothelial proliferation, but you can see here some abnormalities in the stroma which have clearly got loss of BAP1. I find it very useful to see staining of native cells in the background to know the immunohistochemistry has worked, and I think this is very important. Historically, this would probably have just been called an atypical mesothelial proliferation, but now we can say with confidence that this is a diffuse mesothelioma. Similarly, in a more pleomorphic or sarcomatoid tumor here, we have MTAP loss. And these have largely taken over from other immunohistochemistry, such as EMA, as an example. Of course, it's not just we have to go straight to molecular pathology or immunohistochemistry. Morphology, looking for invasion. A simple cytokeratin may show invasion of subpleural fat that was otherwise not relevant or identified. And there are other facets of invasion. For example, here you can see a mesothelioma invading into the peripheral lung, which I also find quite valuable and diagnostic. And then there are other basic morphological and immunohistochemical features, such as irregular infiltrative architecture, collagen necrosis, mitotic activity away from the pleural surface, and irregular staining with cytokeratins. So it is very much morphology, immunohistochemistry, and morphology for this particular setting. So if we have made a diagnosis of malignancy, we can then move on to the differential diagnosis. Morphology, although most mesotheliomas are diffuse and most other diseases are more localized, here we have a mesothelioma, here we have a metastatic teratoma. So you always, I think, need histology to confirm the diagnosis of mesothelioma and exclude other potential tumors. And we again divide this into epithelioid and spindle cell proliferations, epithelioid versus metastatic carcinomas, lymphoproliferative disease, spindle cell proliferations against mesenchymal tumors. I approach this in a phased way. I think it's useful to do a simple round of immunohistochemistry first, especially if there is only a small volume of tissue. We know it's malignant. We can do 4 antibodies, 2 mesothelial, 2 epithelial, plus or minus a TTF1. That will probably give you your answer in, I think, 80 to 90% of cases. If the diagnosis is not conclusive, then I would move to a broader immunohistochemical panel, maybe bring in mesenchymal markers if you're considering an epithelioid mesenchymal tumor, a broader spectrum of cytokeratins, lymphoid markers, melanoma markers, markers of metastatic carcinoma sites. BAP1 can be of value because it's pretty rare outside of mesothelioma. And then for the more pleomorphic tumours, SMARCA4 and NUT immunohistochemistry. Probably as important is right at the top here, discussed with a clinical team. And on the right here, you have an atlas from the RSLC, which, although a few years old, still carries much of this information. The information from the clinical team is valuable because if they say, oh, we didn't tell you there has been a renal cancer or a squamous cancer, then the antibody panels that you might use in that second round will be different depending on if and what tumour has been present. And there's a very nice review by many of the international experts on mesothelioma published last year in the archives of pathology and laboratory medicine. And then if you still don't have a definitive answer, you probably do all the other antibodies and then consider molecular analysis, which I will come to. Just to touch on well-differentiated papillary mesothelial tumour, these generally present in the peritoneum, but can present in the pleura. They are a single layer of mildly atypical mesothelial cells with stromal cores and little or no invasion. And I think if you see any invasion, you have to have a high index of suspicion that this may be just a well-differentiated area of a diffuse mesothelioma, as shown on the right here, where there's a largely papillary tumour, perhaps with a little bit of invasion, but in the larger sample that subsequently came, you can see there is a more diffuse mesothelioma deep to the papillary tumour on the surface. Again, they have a different molecular profile, so this can be valuable if there is some doubt. And the same goes for adenomatoid tumours, again very rare in the pleura, but a different molecular profile if there is any difficulty. Localized mesotheliomas, much less common. The important thing is to think about it, especially if you don't have any positive staining for epithelial markers. And in terms of molecular subtypes, they seem to span out between the characteristics of diffuse mesothelioma and the rarer variants, with some also showing gene rearrangements, which I will come to next. I don't really have much time to talk about the spindle cell malignancies, other than to say you use, or the lymphohistiocytoid variants, other than to say I use a similar profile of using different rounds of immunohistochemistry, with cytokeratin probably being the most important, because if you have something that looks malignant with strong cytokeratin staining, it generally takes out sarcomas, and you're left with sarcomatoid mesothelioma versus sarcomatoid carcinomas, and then you can perhaps move on to molecular pathology to help you from that setting. And lastly, if you see osteosarcomatous or chondrosarcomatous change, just be aware that these can be seen as heterologous dedifferentiation within some mesotheliomas, so it should still be considered. So for the last 3 minutes, a little bit about molecular pathology. This is becoming increasingly relevant. This is a list of thoracic rarer tumours, and in red you have all those tumours that may present in the pleural space. And so it's not just about treatment decisions, it's also aiding in diagnosis, particularly outside of lung cancer. Here's an example of someone with a localized mass. The immunohistochemistry was not definitive despite several rounds. Because of the Burr EP4 staining and the MOC31 staining, I favoured this being a non-small cell carcinoma as it was localized. We sent it off for molecular testing for potential targets, and it came back with a BAP1 mutation. And as earlier, given the rarity of BAP1 mutations in lung cancer, this made me change my diagnosis to epithelioid mesothelioma. Here we have another case, again with immunohistochemistry after several rounds not being definitive. some WT1 expression, but also P40 expression, and some Bury P4 expression. So we favoured this being a carcinoma rather than mesothelioma. We sent it off again for targets. It came back with a nut gene rearrangement. So this was a thoracic nut carcinoma involving the pleura. A third case of a long-standing cystic mass in the pleura with spindled and epithelioid morphology and some clear cell changes. Positive staining for cytokeratins as well as WT1, but also weak hormone receptors and diffuse positivity for desmin. So there was a wide differential diagnosis, including mesothelioma, outside of mesothelioma, mainly looking at various sarcomas. We sent this off for molecular testing, and this came back with a gene fusion and is part of the gene fusion malignant epithelioid neoplasms that we are increasingly seeing in the mesothelioma lined cavities. And then finally, a young patient with a peritoneal mass, which was malignant, again showed a slightly overlapping immunohistochemical profile with some WT1, but also positivity for Bury P4. We favoured this being an epithelioid mesothelioma because there was some invasion, and we sent it off looking for potential targets, and it came back with a BRAF V600 mutation. Now there is a very occasional, there's one case report that I'm aware of showing this, but it then gives a potential avenue for targeted therapy. And on that note, the last thing to show you is this paper, again looking at ALK gene rearrangements in mesotheliomas. So I would say that if you have a young patient, sending material for molecular testing is increasingly relevant. So to conclude, accurate and consistent classification using the WHO 2021 terminology and the various data sets available for as companions for this, staging using the UICC, immunohistochemistry, judicious use in case it requires molecular analysis, and I use a sequential process. And in relation to molecular pathology, this is increasing for suspected and diagnosed mesothelial tumours, both pleural and peritoneal, especially in younger patients, with other methods of testing available if next generation sequencing fails. And I'm sure this will increase as time goes on. And what I'm finding is the more you look, the more you find. And finally, this is a multidisciplinary process, and I acknowledge all these people in relation to the RSLC Pathology Committee, the Eurocan group in 2020, and my colleagues in and around the world. Thank you very much.